Good morning, everybody. I'm gonna talk about a Sentinel article today, but before we start, does anyone have any questions, issues, problems, things they'd like to hear about in the future, cases?
Krista, do you have something?
The delay is so funny.
Do you have something you want to talk about, Krista?
No, we're just really slow out here in Elko. So.
All right, well, we'll get started. I do have some slides that go along with the article, not a ton, but the good news about the slides is I put some links to some of the information you might want to use. So every once in a while, I just like to talk about an article that came out that's sort of a Sentinel article in sports medicine. And this article, it's not Sentinel because I'm going to tell you a whole bunch of new things about concussion in pediatric patients, but it is Sentinel because we've never had a guideline at all. So we've always said, well, treat the 2 to 18-year-olds a little bit differently, but we're not exactly sure how. We're still not exactly sure how when it comes to concussion, but this guideline actually gives you, as clinicians, a little more formal way to evaluate these. And the nice thing about this guideline is it does reference some forms that you can use in the clinic. And I think when it comes to concussion, it's kind of a little complicated when you start doing all the evaluation. So if you have something, that is consistent that you can use on all your patients, I think it's probably helpful. And I do that when I see patients with concussion. So this one is from the CDC, is published by the CDC, and it's a guideline on the diagnosis and management of, they're now calling it mild traumatic brain injury. They prefer that over pediatric concussion, but throughout this whole article, I will still say pediatric concussion because more people are familiar with that. So this came out again recently in September of 2018, and it is the first guideline to ever actually address this. I'm not going to go through all the methodology that they use, but they looked at a number of studies. They did a systematic review of scientific literature over about 25 years. And then they came up with about 19 clinical recommendations for what we should be doing with pediatrics. And again, this isn't going to be remarkably different from what we're already doing, but at least we're getting a little more information based on some scientific studies about what we should be doing. So if you go to the cdc.gov, they have this now traumatic brain injury site, and they've got all kinds of different guidelines, and they can, you could probably find 50 different things. That's the problem. You sort of have to pick and choose what you want. But this little checklist basically comes directly out of the article. So if you just want to get this checklist, I know you can't see it very well on a slide, but if you just want to download that and read through it or keep it in your office, this pretty much covers every single thing in the whole article. So I thought that's a nice little, I like little simple cheat sheets. There's a nice little cheat sheet checklist for you, and that's where to go get it. So when we talk about mild traumatic brain injury or concussions in kids, it's really, really common. And 70% of all those that we see of all concussions that you see in the ER are in patients 19 years or younger. Probably part of that is because we have pushed the kind of, oh my gosh, don't let your kid get so many concussions. Oh my gosh, if they have one, they should be evaluated, which is good. But now a 25-year-old who falls off the ladder in his driveway isn't as likely to come in as the younger kids are. But 70% of people are 19 or younger. And it's most common in the contact sports, the football, lacrosse, ice hockey, and soccer. And for women, soccer is really high. And 70% of the time it's from athletes colliding with each other. So as you get better in your sport, as you get older, that happens a little bit less. Of course, football is always different, but even in the college and professional athletes, they're a little bit better to avoid some of those things. So many of these injuries happen in the younger population. Oh, I had to put in a little ploy for the rural students because this is a totally different article, but I thought it was interesting. And keep in mind, it's pushed by the national athletic trainers who want to have an athletic trainer in every high school, which would be wonderful. But logistically and financially, that doesn't happen. They did come out and they said, if you're in a rural area, and this was back east, more in Minnesota, Michigan, that area, they said you were 50% more likely to have a sports-related concussion that either wasn't diagnosed, wasn't assessed correctly, or wasn't managed according to guidelines. I thought that's pretty interesting, but I do think it's probably because we don't have the ability to have as many people there as you might like at a big school in Reno. But again, if you're trying to push for getting an athletic trainer at your high school or in your group that might go to a high school, this was a good article that came out and said, hey, we could do a lot better in the rural areas managing concussion. And of course, that's just kind of a global look in these states. That doesn't mean that you aren't doing a good job in your areas, and that's why you're here listening. But I thought I would put that in because they do say the rural students tend not to have as much contact with athletic trainers who can help manage these. So when you're doing your so what this article is going to do, again, it's going to go through all the times where a concussion might either come up or happen, and then the management. So they do give some guidelines for the pre-participation exam, and they say, hey, when you have a student athlete in your office, maybe you ought to assess them for risk of concussion. And certainly if I have one who's had 3 concussions, I'm going to think this is a student who's at risk for more concussions for whatever reason, and we're going to have a talk about what sports and how can we change things. But really, some of the increased risk of injury is that they've had a history of concussion before. That's one of the big risks. The older age children and the adolescents, they're more powerful, they're running faster, they're colliding, they're still not quite as coordinated as a 25-year-old. Folks who have pre-injury neurological or psychiatric diagnoses, so whether it's a learning disability, it's depression, it's migraines, it's ADHD, those things interact with the mild traumatic brain injury concussion, and sometimes they take longer to get better. So sometimes you can just talk ahead of time about, hey, what sport, maybe this is a good idea, maybe this isn't. You know, I've had 2 concussions already, I have ADHD and I'm treated for migraines. Should we pick football or should you go for the golf team? You know, it's a talk you can have. We want kids to participate in sports as safely as possible. So it's just something to consider. Females tend to take longer to get better. And then families that have some upheaval, maybe some social or psychosocial stressors. So again, depending on if you find any of these things or you just sort of want to do a general talk about a concussion during the pre-participation exam, if you have time, those are some of the things that they suggest. And then after the injury, say this is somebody that comes into your office, it's great if you already know the student or the child. If you don't, you know, these are again some of the things that when we talk about a poor prognosis, we don't mean they're going to go on to chronic traumatic encephalopathy. What they're talking about is, hey, this person might not get better in that usual about 1 month time frame. So 1 to 3 weeks is kind of an average. It can be up to 1 to 3 months. These are kids that might push toward the 3-month range. And again, it's older children. They found Hispanic ethnicity made a difference. Lower socioeconomic status, history of an intracranial injury, so had a concussion this time, but had a more serious injury or had a more serious injury in the past and now have a concussion. And again, either have a history of pediatric concussion in the past or what we call baseline pre-injury symptoms. Now, not everybody does a baseline screening, but some of the computerized neuropsychological testing that's done, you actually, if I go in, I'm getting ready to play football, I actually fill out a form and say I have these symptoms. And when you look at those symptoms, they're very non-specific for concussion. They're things like, I feel sluggish, I have a headache, I feel depressed, I don't sleep well. It can encompass a lot of different things. So folks who already have all those symptoms, then get a concussion, seem to have a harder time getting better afterward. Neurologic or psychiatric disorders, again, a lot of those symptoms and a lot of those complaints can overlap, and it becomes a little bit more complicated. Again, talk about learning difficulties, cognitive ability, and the family and social stressors. So those are things that if you have a student come in, and again, you may know this person, and they have 1 or 2 or 3 of these things, you might want to see them a little more often, or talk to them a little bit about, hey, it might take you a little bit longer. You might not be back in 2 weeks. Let's just see how it goes, or not. You might not want to put that in their mind and say, hey, this is going to happen to you, but you do want to keep a closer eye on them. So when they come in, and we'll say they're in your office at this point, but you could also see this on the sideline if any of you do sideline coverage, or you're on call on the weekend, or you're there on Friday night for football. You want to, always, you want to make sure that you don't have something more serious going on than a mild traumatic brain injury. So a moderate or a major traumatic brain injury. So if you find symptoms that may suggest more severe injury, and they suggest a couple here, if you see some blood in the ear, the eardrum, or the pupils are asymmetric, if they have other injuries that might affect recovery. Oculomotor dysfunction is one of the things that can happen with concussions, and it's where, have you ever heard of the King-Devick test? There's a test called the King-Devick test that basically you read across and down, and you do a baseline, and then if they think you have a concussion, you can use it on the sideline, and you can time them and see, are they a lot faster or are they much slower, because a lot of times a concussion can affect the eye movements. I always, again, when I would teach the fellows, I'd always say, head's connected to the neck, make sure you're not dealing with a neck injury too. Scalp hematoma, and then can there be another medical condition that's interfering? A heat illness, a cardiac thing, sometimes has been confused as a head injury because they have mental status changes, and those, exertional heat illness or a cardiac condition can kill a student athlete fairly quickly. So you want to make sure, hey, just because it seems like their mental status has changed, I'm not only going to blame it on a concussion. I'm going to evaluate them. I'm going to look at their vital signs, and then I'll decide, is this a brain injury or is there something else going on? So that, again, you may not be assessing for some of these things in the office because you might not see them for 3 days if it happened on a Friday night and parents or someone brings them in on a Monday or a Tuesday. But those are the same things. Neuroimaging, they're really asking us not to routinely order CAT scans unless, of course, you think it's clinically indicated. And if you're worried, or you have a parent who's so worried you feel like, hey, the risks and the benefits, I'm going to go ahead with it. But what they're saying is really try to use some kind of a clinical decision-making tool before you do these CTs, because there is a little bit of a worry now that radiation may cause an increase in lifetime cancer risk. So everybody walks through the door that says, hey, I hit my head this morning, and they're 7 and they look fine and they can walk and talk and have a normal neurologic exam. Maybe they don't always need a CAT scan. We do a lot of CAT scans on kids that don't need it. And again, we're worried about that. So the good news is the Pediatric Emergency Care Applied Research Network gave us some decision rules. And again, you can go get these and print them out. But we have these in the ERs where I work. And I just go look. A lot of the newer EMRs also, you can say under clinical decision making, I've decided to do a CT because this, and this, or I've decided not to because none of these were present. So it can help your documentation. But again, the best thing about these type of things is it helps patient care. You can look at it. These are validated tools. This is the one I use a lot. And so you just go through this. Yes, they get a CAT. No. Maybe we can observe low risk down here. The chance of them having an intracranial injury in this low risk category in the middle is 0.05%. And so that risk, the chance of that is probably less than doing a CAT scan and possibly increasing their risk of cancer in the future. So again, these are nice. These PCARN tools are nice to have to decide, hey, should I or not? Now, all of that aside, there are situations where I just feel like I want to do this. I have a parent who's really, really worried and we have some kind of symptoms. A lot of times I'll have a long talk with the parents about the radiation and how well the child looks and doesn't fit any of these, and the parents are like, oh, I don't want a CAT scan then. But you'll run into, this takes a little bit of education sometimes. But these are nice tools to have, I think, if you're on the front line trying to decide, do I CT this child or not? So again, you can get those off the internet. This one came from the California Emergency Physician site, but they're all over the place. So one of the things that they ask us to do now is some type of an age-appropriate validated symptom rating scale. Well, a lot of these aren't, there are a lot of them out there. A lot of them aren't validated yet because we haven't done these studies in pediatrics, but they give you a list of some that are, and I think, oh my gosh, I could go out there and download any one of these, and they're all a little bit different, and what should I use? Well, at the very bottom, I put this little ACE, the Acute Concussion Evaluation, and the ACE Care Plan, and I put links for you because I think these are pretty easy to use. Every single tool I look at, I wish I could tweak it a little bit, but this one, so those are the links there. I'm just gonna, so what, I think it's down a little bit further. You can see these are just kind of scales that are easy for you to use. And you can see all the same stuff, headache, nausea, balance problems. Here's another post-concussion symptom scale. I just put some pictures in there. Here's where you can go get those forms. I learned how to use my pen to circle the, And this is the form, again, that you can't see, but the good news is it's one page. And it assesses some of the things. So again, in the day and age of EMRs, it's a little bit difficult. Can someone put this in your EMR for you? Yeah. What do? We actually fill it out and scan it in and reference it in the note. Again, not ideal. This stuff will evolve. But the good news is this is a standard form that addresses most of the things you ought to be looking at. And I like to have something like that because then I don't miss things. And then I don't have to write out a really huge, long typed note because my EMR doesn't have a concussion template. If yours does and it addresses most of that, that's great. If it doesn't and you want something to use that's fairly simple, that comes with a follow-up plan, I think of all the things that are out there, this one's probably a reasonable one to choose. If you're using something else, that's okay too. Just look through these and say, yeah, I'm pretty much addressing these things when someone comes in. But that's a good one. It's easy to get. You can download it and use it. The CDC's made it available. And again, it's on that same site. So everybody wants to know, when should I go to the ER? What happens? Do I have to wake them up every 3 hours? What do I do? So you always want to counsel about the warning signs. And so certainly worsening headaches that don't go away, subdural can present like that. Significant nausea or repeated episodes of vomiting, again in the PCARN rules and the trauma rules. Hey, you vomit a couple times, you got to get your scan. Increased confusion, restlessness, agitation, not acting normally. The slurred speech, drowsiness, can't wake them up. Weakness, numbness, loss of coordination, certainly loss of consciousness, convulsions, or seizures. So you always, after you do your evaluation, and this is typically right after the injury, hey, these are the things to look for. And the nice thing about that ACE form that I just showed you is they have a follow-up form for school and work that also addresses some of these warning signs. And then really, especially with kids and younger folks, I know they want to get back to the game, but if we're talking about the junior high basketball game, brain's probably more important. It's going to take 1 to 3 weeks. Maybe there's a way for you to discuss how to prevent further injury. Maybe there's not. Sometimes it's, hey, I just fell down and hit someone's knee, and that's how it goes. You tell them that they're going to have to get all the way better. Then you're going to gradually reintroduce activity. They do need social and emotional support. When we used to take kids and say, okay, you're out of your sport, you're away from school, you're away from your teammates, you're going to be in a dark room for a week while your headache gets better, they actually did worse. So if you can sit on the sideline you can't dress out and play, but you can be with your team. You can be at school. You may not be taking the SAT the next day, but trying not to totally isolate them and take them away from everything is important. And then again, trying to use some kind of a combination of tools to assess recovery, not just for a 15-year-old who really wants to play. How you feeling? Great. Okay, you can go back. So that's where some of the symptom scales come in, the balance testing, the cognitive testing, some of the reaction time stuff. I don't know exactly what you have where you are. Some of the neuropsych testing, the computerized testing will address some of these things. And then really, it's great if you can see these people and have some continuity with them. It may not always work out that way, but again, this is something that happened. The brain's going to need some time to recover. Here's the typical recovery, but it may take up to 3 months. If you think you have somebody who you already know had some problems and you're worried about they are going to have persistent symptoms, they're going to have a prolonged course, maybe you see them a little bit sooner. Risk factors for prolonged recovery are the ones that are really, really symptomatic, either right afterward or the next day. The scale is off the charts, it's really high. If they've had previous history of concussions, again, some of the other stuff that they looked at, and girls, as we talked about before, the female sex. And so again, for you, if you have an athletic trainer, sometimes they're helping manage this, but this might be they're coming back in to see you. So at this point, we're sort of doing what we call relative rest. So instead of you have to be in the dark room for a week and not do anything at all, we do sort of a relative rest. So maybe you can walk right afterward, but we don't want you running the marathon. Again, maybe you can go sit in class if, it's a literature class and someone's reading that day where you don't have to do a lot of screen time, a lot of difficult mental calculations. So again, this is kind of where the art of medicine comes in. Is it Friday? Great. Maybe by Monday you'll be able to go back to school and tolerate classes. Again, maybe not take a big test, but can we get you back? So sort of some restrictive mental and physical activity for the first couple days. Instead of saying, you're not going to get to do anything at all for a month, hey, for a couple days, let your brain rest. It's like we say with all the other injuries, your knee's this big, your ankle's this big. Let's give it a couple days and then we'll start moving things and we'll start doing some rehab. What's going to happen is they're going to have more restrictive mental and physical activity for a first couple days, and then you can do some gradual return to activity or play that doesn't significantly exacerbate symptoms. So again, this might be, hey, you can walk out and you can walk around the track a little bit today. It's been 4 or 5 days. So that they get to do something, not everything is just taken away. And you want to use some kind of a tool to monitor their symptom score. And it's nice to use the same one every time because then you can say, hey, they scored a 63 here. Oh, good. 2 days later, we're down to 39. Gosh, 5 days later, we're down to 3. And that's one way to follow recovery. If you have the computerized neuropsychological testing, that does a symptom scale too. And you get a little separate printout where here's the symptom scale or here's their score on the symptoms. And then you're going to include your follow-up instructions for clearance. So how we return them to activity, again, we used to say, hey, rest until all your symptoms are gone, and that might have been 3 weeks and they couldn't do anything, and a lot of times patients and parents are obedient, and so they weren't doing anything. You can walk from the house to the car and that's all, and what we're finding is probably some light activity may actually increase resolution of concussion. So we're moving away from total rest to sort of this relative rest or some symptoms or some activity that doesn't significantly worsen symptoms. Not talking about putting them back in a contact situation that early, but what we're talking about is, yeah, maybe you can ride the stationary bike at practice a little bit or at the gym, or you can take a walk with the dog, stuff like that. Again, you're going to have to kind of assess school needs, and this is individual because Somebody with ADHD and a learning disability and now a bad concussion is going to take longer and need more help with school and a plan than maybe somebody who doesn't have those as many symptoms, had their concussion on a Thursday or a Friday, they've gotten a couple days and they're feeling pretty good about school, and maybe it's the beginning of the semester and there's not a lot of hard tests and work. So again, you're going to have to look a little bit about and ask about that. If you're at school, you're somebody who works in the education system, the school nurses, some of the counselors can help with this. And sometimes you don't have that and it's just you, and you're going to have to talk with parents and have them talk with teachers. Once they get back to their regular non-sports activities, including school, then you can begin your return to sport. But you don't want to return to sport when you're still not back in school. So make sure that they can, cognitive abilities are back and they're able to do those kind of things, and then you can return to sport. And again, what we really say, if you didn't have anything at all to go by, how do you get someone back to sport? Well, they really need to be symptom-free with non-contact exertion and not be on any pain medicine. So if they're still taking Advil 3 times a day, hey, I don't have any symptoms, and as I was able to run today, can I return? No, we got to get you back off those pain medications. Hopefully we're talking about non-opioid pain medications, Tylenol, Advil, those type of things. And then symptom-free with non-contact exertion, then they can begin their return to play progression. And this is the same just about everywhere. This should be about 24 hours per step, especially in younger kids. And that's the return to play progression. And you can find that any place. Refer, I think first off, refer if you're uncomfortable, you think they have a more serious injury that you're not comfortable managing, off they go. Certainly symptoms at 4 to 6 weeks, still having a lot of symptoms given standard care, probably time to send them someplace else. I know it's hard when you're 3 hours away, and then trying to get a neurology appointment is really difficult. And it varies depending on, sometimes we have neurologists that are really interested and will see these right away. It depends on what community you are and where you can send them. And then sometimes your favorite neurologist leaves, like mine just did. Now I'm looking around for another one who will see them right away for me. Because you don't want to wait 3 months when you're already worried that someone's had symptoms at 4 to 6 weeks. So again, can be a little tricky, but if you're uncomfortable and they're not getting better, certainly if they're acutely worsening afterward, they need some type of neuroimaging study, and a non-contrast CT is to start. Hey, I don't have a bleed, I don't have any major trauma, or I do, and then I really need to get them somewhere emergently. The chronic headaches and the non-opioid analgesia, again, if you're using it every day for more than 2 weeks, you can have overuse, and then when they start to go off of those kind of medications, you can have some rebound headaches. So again, something else to monitor. Use these medicines when you need it for a headache, but if you don't need it, you don't have to take it on a regular basis. Again, some of the vestibulo-ocular stuff, especially if you're doing the CKDs or the H, and they're really having a lot of symptoms that are prompted either by reading or visual eye movements. There are some places actually that will now do some vestibulo-ocular rehab. Again, hard to find, but you can find some physical therapists even that are interested in doing that. Sleep problems, again, maybe something that you end up referring. Some of those have had trouble before, and gee, the depression, and now it's worse. So you may need to get other types of specialists besides neurology. If you think you're having ongoing cognitive impairment, they really should have a neuropsych evaluation, and that would be in person with a neuropsychologist, not just a computerized neuropsych concussion test. And then again, if there's a lot of emotional dysfunction going on after a concussion, you do see patients who really have difficulty with emotions. If that's not resolving, you might need to say, hey, is there something else going on? Are there some of those family psychosocial stressors? Or is there something prior? Are we dealing with some depression and a concussion? Those things are hard, and you might need to refer and get some help with that. So key points today. There's a new guideline. You can read it. Again, none of this, I think, is ice-breakingly new, but maybe it gives you some ideas on, hey, here's a standard form I can use. Here's a standard way I can assess these. Gosh, here are some of the things that might make it worse. I might want to refer earlier, or I might want to address with a student or their parents. Again, if you have time and you're doing pre-participation exams and you see somebody who you think this could be a setup for a concussion or has already had some and is still playing a sport, where that's likely, it might be something you want to talk about. That not everybody with a concussion needs neuroimaging, but try to use some of those clinical guidelines to help you. Again, that's good patient care, it's good documentation, and it may prevent a little bit of the CT overuse that we're seeing. Try to use an age-appropriate validated symptom scale. Now that this article, that this study, the guideline is out, there'll probably be some more of those evolving that may be easier. And one might come out and say, this is the one we want to use. But for right now, you can pick one of those. I put them in there. Again, you can go find those on the internet if you just type it in. You do want to educate patients and parents and coaches about recovery. Hey, this is probably at least 1 to 3 weeks, and it might be 1 to 3 months. You know, don't say you're going to be back in 4 or 5 days and you've got somebody who's going to be a 3 month. Everybody gets nervous about that. Monitor patients for persistent symptoms. So if you have the ability to see them back and there's somebody that you can provide continuity for, you can watch them and monitor them. And I think giving some reassurance is good as long as you think, hey, everything's going along okay, because a lot of people are really scared about concussions. We did our job in educating and saying, hey, everybody, we're having too many concussions that are being treated too lightly or not treated or not addressed. We're letting kids go back to too soon. And now everybody's really, really worried about them. And so sometimes I think you can say, look, you're not set up for long persistent symptoms. You should recover. This is, good sleep, good nutrition. We're going to give you some gentle exercise, follow up, and some reassurance I think is good, because most kids do great after these and don't have any long-term problems. And then somebody in your group or works with you, whether it's school, do you have an athletic trainer? Is it an athletic director? Do you have a physical therapist? Is it you? Somebody should manage the return to play, that they don't go back too soon. That risks additional injury, additional brain injury if the concussion's not healed, but B, if their concussion isn't healed and they're having some problems with balance, they're having some problems with cognitive, their peripheral vision, their oculomotor, it puts them at increased risk for other injuries, like an ACL injury. Now you've got a whole nother problem. So you don't want to return them to play before they're ready. And I think in that little slide that I said about the rural students, they typically return 2.5 days earlier than students who are monitored by an athletic trainer. And you can think there's probably a lot of different reasons for that, but returning them too early probably isn't a good thing. I'd rather you wait and return them 2 days later. I know not everybody, as far as parents and coaches and kids, would want to do that, but I'd rather wait a little longer if you're not sure than put them back too early. So that's for you to manage the return to play. So again, nothing earth-shattering in these guidelines other than maybe here's a few more standardized things that you can use, and or maybe it just says, hey, I'm already doing all the right things, and stay tuned for now there'll be some newer guidelines and probably some newer forms for us to use. All right, questions about anything right now?
Dr. Scott, are you going to post your presentation?
Yeah, I think I posted them, but I can send them to you directly, Krista.
Or I could just pull it off the site. It's fine.
Okay.
No worries.
Yeah. And so there's some references at the end too that reference that site. Most of it's on the CDC site, and you can get all those forms there. Now, like I said, I just like to use the same thing. I have my little standard form, and again, it's kind of a pain because I still have to, part of it is a symptom score that the patient fills out, and then I have to scan it in because we, at least at Student Health, we aren't sophisticated enough to have an EMR that can put that in. You might be able to, or you could scan it in, or if people are still using paper, you can do that. But I think it's just nice to have some type of a form that you can follow. You don't forget things. You kind of remember what to do. And then you've got good documentation. And if you're noticing, hey, there's something really off, patient gets referred. So it's always about good patient care. And I think, especially if you're doing a couple concussions a year, it's like, let's see, did I get that symptom score? And I like to see my patients back and see how they're doing as far as their symptom score. That really tells me what the prognosis is going to be. Now, if I see them back in a week and they went from a 39 to a 2, well, this is a good sign. I'm going to probably be able to get this student back a little bit sooner than, hey, it started out at a 75 and a week later they're at a 73, and I'm like, uh-oh. At that point, I start looking, do they have anything else going on besides the, mild traumatic brain injury? The students I'm dealing with are typically a little bit older than this group. And with the younger students, we've always said, or the younger patients, we've always said, give them a little bit longer, don't rush them back. We'd rather you delay and let everything heal up. So I think that 1 to 3 week guideline is good. And you may say, hey, most of these take 10 days to 3 weeks. We're probably not going to return you before that. And then if you consider it took 3 weeks for symptoms to be gone, and now you've got a graded return to play that should take about 6 or 7 days, you can really say to patients and parents and coaches, it's probably a month. And then, it takes a little bit of that, but I got to be ready for the game this weekend. It's not going to happen. And this is why, I really want you to get better. This is your brain. There's some significant problems if we return you too soon. So again, I think it gives you a little more ammunition in that, hey, we want this to be all the way better before we put you back out there.
Great talk. Thank you.
Michael, do you have any questions?
No questions on our part. Thank you.
All right, thanks.
Okay, anybody have any topics that you want to hear about? Okay, if you think of any, email us, and we'll come up with a few more things in the future. I've got some people lined up. I get Dr. Malcarney back because I always like to hear about shoulders, so you do too. So she's going to come in a couple months and talk about rotator cuff. We've got Dr. Hall going to talk about methicillin-resistant staph, kind of give us an update. That was big about 5 or 6 years ago. It hasn't gone away, probably getting worse. Anyway, I did a little short talk on just energy drinks in general because been some more studies saying those may be causing more problems than we realize, especially when younger kids are drinking those. And we might have somebody talk about the keto diet, if anyone's interested in hearing about. I always hate there's something new and I go to read about it. I'm like, it's not really new, it's just disguised. But I always like to have somebody kind of fill me in. So if you can think of other sports medicine topics that you want, or you just want, let's go over a knee exam, an ankle, a shoulder, something like that, let me know and I will either do it or we'll bring somebody in to do it for you. Okay, thanks everybody. Have a good day.
Thanks.